Assalamualaikum and hello everyone. We are from group 6B. We present about acute stroke with left hemiparesis. The case is about a female patient. She is Indian and her age is 55 years old. Her current weight is 60 kilogram and his height is 155 centimeter. So his BMI is 25, which shows that she is a bit overweight. So our patient has diabetes, hypertension, bronchial asthma, dyslipidemia, fibroid, and she also has been admitted to the hospital on 12 January until 15 January due to the URTI with bronchospasm and electrolyte imbalance. For past medication history, she had been received metformin 500 mg/bd, Mistad 10 unit ON, and glycoside 80 mg/bd for diabetes, and she also had been received amlodipine bacillate 5 mg/bd to treat his hypertension. She also had been received simvastatin 20 mg ON for dyslipidemia. She also had been receiving medroxyprogesterone acetate 5 mg/bd, tranexamic acid 2 capsule QID, and also neurobion 1 tablet OD. The occupation of the patient is a teacher. Then the patient also is not a smoker and do not take any alcohol intake. For family history, her father has a stroke. All his siblings have diabetes, which is her eldest, second, and younger brothers have coronary bypass surgery. On 24 March, she had syncopal attack during working. The patient also had complained having a severe headache on the right side. The patient also complained about having a fever, chest pain, SOB, URTI symptoms, and slurred speech. After she had syncopal attack, the patient unable to lift the left upper lid. On 24 March, she had been diagnosed with acute stroke with left hemiparesis and uncontrolled diabetes.
Next, I will briefly explain progress of the patient in the ward. Patient was admitted to the hospital with left side weakness, headache, giddiness, and abnormal rapid breathing. Both her BP and glucose level were high. CT brain results showed that there was hyperdense over the right occipital region, which is the backside of the brain. She was then prescribed with potassium chloride, hydrocortisone, aspirin, atropine insulin, cardioprin, and atorvastatin. On the next day, her BP and glucose level keep on increasing while her potassium level gradually decreased. So, they increased her insulin dose and add a basal insulin while her potassium imbalance was fast corrected using potassium chloride. For the next 2 days, the patient was still having fever and her BP keep on worsening. So she was given peridoprid for the uncontrolled BP and they initiate antibiotic therapy as there was a sign of infection. Next, we move to the DRP. Patient received subtherapeutic dose of peridoprid and insulated insulin. Based on the drug information handbook, the initiation dose of peridoprid is 4 mg OD and titrated based on patient response, while for the insulin, the minimum dose based on her weight is 18 IU. However, she was given with only 14 IU per day. There were also potential drug-drug interaction. The first one is interaction between peridoprid and low-dose aspirin. Combination of these drugs may reduce the kidney function. The second one is between potassium chloride and peridoprid. Peridoprid may increase potassium level in the body that can eventually lead to kidney failure, muscle paralysis, irregular heart rhythm, and cardiac arrest. Lastly, interaction of low-dose aspirin with insulin. Concomitant use of low-dose aspirin with insulin may lead to hypoglycemia. Patient might experience symptoms like headache, dizziness, and drowsiness. Pharmaceutical care issues in this patient are the uncontrolled blood glucose level and blood pressure level despite taking the medication as prescribed. High BP and uncontrolled glucose level were also the risk factors for stroke. Besides that, she also has mobility problem after the attack, which can also affect her quality of life. Next, her potassium level also was low even though she had been infused with potassium chlorides. Lastly, since this patient has low albumin level, the activity of drugs that are highly albumin bound such as atorvastatin and peridoprid may be altered. For her current diagnosis, she was diagnosed with acute stroke with left hemiparesis. Evidences for her diagnosis are history of syncopal attack, and after the attack, she was unable to lift her left upper limb and unable to walk. She was also presented with slurred speech. Besides that, her CT brain also indicates there was a right thalamic infarct. The patient also has a few risk factors for stroke, such as high BP, high glucose level, high cholesterol, history of stroke of the family member, and the increasing of age. As the older the person, the greater their risk for stroke. She also was diagnosed with uncontrolled blood pressure and blood glucose level. This is because the reading of the parameters for both conditions exceed the recommended range. There was also sign of infection as she was having fever, spiking of blood pressure, and also high level of CRP.
So we're moving on to the recommendation treatment. Since the patient has been diagnosed with acute stroke, the general management of acute ischemic stroke based on the CPG guideline. One of the management is by giving the oxygen and airway support. This is because it can help to ensure the clear airway and adequate oxygenation in order to prevent the hypoxia and potential worsening of neurological injury. Next, mobilize yearly to prevent the general and neurological complication. The guideline also state that if the patient has a blood pressure, do not treat the hypertension if the level of the hypertension is less than 222 mm mercury systolic or less than 120 mm mercury diastolic. If the patient has a very high blood pressure, so the level of blood pressure must reduce gradually in order to prevent any complication. Since the patient has diabetes, we need to treat the patient with the insulin. If the patient show any hypoglycemic symptom such as shakiness, dizziness, or tremor, we need to give the patient glucose to treat his hypoglycemic. If the patient has a malnutrition, we need to perform a water swallow test to the patient. And if the swallow test is failed, we need to insert a nasogastric tube into the patient. Percutaneous endoscopic gastrostomy is only necessary if the patient has a prolonged enteral feeding. If the patient has a fever, such as the level of the WBC is high or the fever is appear, we need to treat the patient with appropriate antibiotics. On 26 March, she has a fever, so we need to give antipyretics such as paracetamol to control the elevated temperature. Based on the guideline, if the patient has high intracranial pressure, the doctor can suggest to the patient to elevate the head of the bed by 20 to 30 degrees because it can help for the venous drainage and hyperventilate the patient to lower the intracranial pressure. The guideline also suggests that to give antiplatelet treatment to the patient, such as aspirin. The dose is around 75 until 325 mg. The purpose of giving the aspirin because it has a long-term secondary prevention in patients with a previous transition ischemic attack or ischemic stroke. It is also reported that aspirin can help to reduce the risk of any recurrent stroke over 3 years. If the patient has a stroke attack within 48 hours, we can suggest to give aspirin to the patient. So next antiplatelet treatment is Triflucel 600 mg. Triflucel can help for secondary prevention of vascular events in patients that has myocardial infarction and stroke because it can help to reduce the incidence of intracranial and GI hemorrhage. The guideline also state that we need to give the antihypertensive treatment such as ACE inhibitor to reduce the current stroke in normotensive and hypertensive patient. And we need to ensure that their level of lipid is within the normal range. If their lipid is high, we need to give the lipid lowering medication such as statin, which can help to reduce the vascular events among the high-risk patient, including the patient that has stroke. So this is the diagram of the stroke management algorithm. As you can see that if the patient has symptom of stroke, so we need to do the evaluation by doing the blood test, ECG and brain CT to know if the patient has the ischemic stroke or hemorrhagic stroke. If the result shows that the patient has an ischemic stroke, we need to give the specific treatment to the patient because different type of the stroke has a different track of the management. Since the patient has been diagnosed with uncontrolled diabetes mellitus, the Malaysia CPG management of type 2 diabetes mellitus state that the patient who has diabetes with acute ischemic stroke, it state that we need to avoid any of hypoglycemic symptom and give the insulin if the oral management cannot achieve the normal target of the glycemic control. And according to the CPG management of ischemic stroke, it states that tight glycemic control is important and be supported by the meta-analysis. So the suggested HbA1c level should less than 6%. Since the patient has hypertension on 26 March, the CPG management of hypertension guidelines state that we need to avoid giving the antihypertensive medication to the patient during the acute phase stroke. The antihypertensive medication can be given to the patient after the patient is stable. And if the RBS level is more than 11 millimole per liter, the CPG guideline also recommend to treat the hyperglycemic with the insulin. More recent guidelines suggested a target of BP after stroke should less than 140 or 90 millimeter mercury. There is one study has shown that the combination of ACE inhibitor and thiazide diuretic can give a beneficial for patient who has hypertension and also stroke. So it can help to improve the condition of the patient. Next, other intervention plans can be suggested to the patient is since the patient BMI is 25, which is categorized as overweight, so we can suggest to the patient to do the healthy lifestyle such as by doing a light exercise and control his diet. And then the lab result also shows that the patient has uncontrolled level of dextrose. Since the patient has using the insulin, maybe she do not know the incorrect technique of using the insulin pen. So pharmacists need to assess and educate the patient on how to use the insulin pen. So we're moving on to the monitoring plan. We need to monitor the liver profile of the patient. Next, we also need to monitor his kidney profile by looking at the level of the serum creatinine and urea level. And then, since the patient is taking a cardioprin, we need to monitor the sign and symptom of the bleeding. The patient also is taking the insulin, so the patient need to monitor any of the hypoglycemic symptom such as tremor. And also the patient needs to monitor the GI symptom. Since the patient is taking the insulin, the patient need to monitor the site of insulin injection. If there is any of redness, swelling and presence of lipohypertrophy, the patient need to inform to the doctor. And then monitor the hydration status by looking at the IO chart, skin sugar, and evaluate the patient physical assessment. In order to know that the medication is effective or not, we need to do the efficacy monitoring, such as by monitor the blood sugar level, blood pressure level, level of electrolyte, lipid profile, and then sign of infection, and make sure that the level of the WBC CRP is within the normal range. And we also need to monitor any sign symptom of the recurrent stroke event. Okay, that's all from us. Thank you for watching our video.